For everybody that's on already, we'll get started in just a minute or two. We'll give folks a minute to try to get on. Right, we still have people joining, so I don't want to get started and then have to constantly hit admit. I don't have anybody else to help admit, so it's just me today. For those that have already joined, looks like got the message. If you could be on mute during the presentation and stay off camera. This is being recorded. It should be on the Florida HFMA YouTube channel. We do have some prior years training as well, so you can certainly refer to that. The material has not changed pretty much since then. HFMA is working on updating materials, so we'll have some new training sessions probably in the fall, but that has not been completed yet. So hopefully those YouTube channels, they've gotten them up there and posted. When we are done, please put questions in the chat. We'll refer to that at the end. If you have a question, as we, certainly at the end, when we open it up for questions, please feel free to come off mute, come off camera, and then be able to have that dialogue at that point in time. So for those of you that don't know me, my name is Christine Fontaine. I am actually the Florida HFMA Certification Chair. I have been helped greatly by two great speakers, Natasha and Cassandra from U of Miami, that have graciously offered to assist in doing these as well. So I look forward to the conversation with you and hopefully seeing all of you certified in the next few months. So as Natasha and Cassandra, I hope told you, this is just a supplement to the CRCR training that is on the HFMA website. So as a member, all of the certifications are free as part of your membership. And there is training that you should be doing at the same time to supplement this. This alone is going to give you some good concepts, but there's a lot more materials. That's a lot more training questions and sample questions for you to do. So make sure you're going through there. And I think between the two of them, certainly should allow you to be able to pass this without any issues at all. So. All right, so let's get started. My apologies real quick. Sometimes it gets stuck in the first slide. Okay, so today we're going to go through sections 3.1 to 3.4 and talk about patient arrival intake, case management, revenue capture, and then coding. As we've done in the past, we're only doing about a half a section each one. There's a lot of material in here. Plus, we want to make sure that we give you enough time at the end for questions about any key concepts that you want to review. So what we're going to do today is we're going to talk about EMTALA and its requirements. We're going to talk about the importance of the Master Patient Index and data collection, physician identification and orders, registration forms, and then bed control. So we're going to walk through a lot of that patient access stuff today. So EMTALA, hopefully most of you have heard of it. EMTALA requires hospitals to provide a medical screening examination and any needed stabilizing treatment to every person presenting at an ED requesting medical evaluation or treatment. Until those obligations are met, the presenting individual can only be transferred out of the facility under very narrowly defined conditions. The screening examination and stabilizing treatment must not be delayed due to inquiries about the patient's method of payment or health insurance status. So typically what you'll see that patients are initially triaged by medical personnel, where a quick registration record is generated to specifically allow order entry. After triage, the patient is either placed in a bed or may return to the waiting room if clinically stable. Once the EMTALA requirements are satisfied, the remaining registration process is completed at bedside or in a registration area. Discharge processing, including the resolution of any patient financial responsibility, may also occur at bedside. Alternatively, discharged patients may be escorted to a discharge desk. For hospitals covered under the IRS 501R regulations, typically you're not-for-profits, right? Required signage concerning the provider's financial assistance policy must be posted in all patient access area and must be done very prominently. Okay. Signage must be easily seen that notifies their patients the right to be seen, examined, and treated, along with the hospital participation in Medicaid. Prior authorization is not allowed for emergency department services prior to medical screening and stabilizing treatment. And for the most part, it is not required for most emergent care at all. Women in active labor must receive services through delivery. A pregnant woman having contractions is considered in true labor unless a physician can certify after a reasonable amount of time in observation that the woman is in false labor. If an on-call physician refuses to attend to the patient or fails to appear within a reasonable time frame, it must be noted in the medical record and disciplinary records as well. Referring a patient to another facility that should be completed while the patient is in the ED will be considered patient dumping. A patient is considered unstable if there is a risk of material deterioration. Exceptions include cases where the facility clearly does not have the appropriate resources to treat the patient. Both a full medical screening and full psychiatric screening must be provided. A central log must be maintained that documents all patients that present to the ED and whether they refuse treatment, was refused treatment, admitted and treated, stabilized and transferred, are discharged. Scheduled patients who have been pre-registered will have completed comprehensive access processing prior to their date of service. These comprehensive access processing activities include identifying the patient in the MPI or creating an MPI for new patients, creating the registration record, completing medical necessity screening, determining health plan eligibility, obtaining health plan benefits, resolving managed care requirements, estimating the patient's financial responsibility, and completing financial education and resolution. Access processing does not occur prior to arrival of the unscheduled patient. Therefore, upon arrival, these patients will require complete access processing and should be directed to a patient access area for registration, including positive patient identification, insurance verification, managed care screening, medical necessity screening and documentation, price estimation, financial counseling, etc. Typically, those are considered lab walk-ins, radiology walk-ins that are not scheduled for some reason, but typically we're talking about labs and walk-in radiologies. Okay. For newborns, initially the mother's registration information is used to generate the newborn registration record. Once the parents have named the baby, the newborn record will be separated from the mother's. Primary care, when we talk about the different types of docs that we need to identify, primary care is usually a family practitioner, a OBGYN, a pediatrician, or a general internist. Referring physician is typically a primary care physician refers a patient to a specialist for care beyond their scope. An attending physician, this is the physician who wrote the order for service and is the physician in charge of the patient's care for a specific period of time, also referred to as the admitting. And the attending physician brings other specialists in to consult for specific areas of concern. So if a patient's primary or attending or admitting doctor is their liver doctor, but there are issues with the kidney, they bring in a kidney specialist to be able to do that. So let me just admit this person, my apologies. Okay. So admission orders. The physician decision on whether a patient should be admitted as an inpatient or become an outpatient patient requires medical judgment based on the patient's medical history, current medical records, and the risk of something adverse happening to the patient. Medical documentation must support the level of care. Patients are admitted to inpatient status if further treatment can be provided in a hospital setting, the patient condition cannot be evaluated and or treated within 24 hours, or there is not an anticipation an improvement in the patient's condition within 24 hours. Hospitals could only convert an inpatient case to observation if the Hospital Utilization Review Committee determines before the patient is discharged and prior to billing that an observation setting would have been more appropriate. Physicians must be notified, agree to, and document this change. Observation services are used to evaluate patients for possible inpatient admission or to resolve problems where treatment is expected to last less than 24 hours. Using observation status allows the physician time to determine if admission is necessary, reduce denials for unnecessary admission, and ensure some payment is received for services rendered. Services that do not qualify include convenience reasons, routine prep, routine recovery, certain therapeutic services, and procedures designed as inpatient only. We do need to know the 2 midnight rule. Physicians need to believe that the patient will be in-house for at least 2 nights to treat their condition, and then they could be admitted. CMS has mandated the use of occurrence code 72 on inpatient bills to denote the date span of contiguous outpatient hospital services that preceded the inpatient admission. So there's some billing qualifiers there as well. So lots of registration forms that we're going to have to review today. So except in emergency services, a consent document should be completed by every patient. It must include 4 conditions: must be related to treatment, must be informed, must be voluntary, must not be obtained through fraud or misrepresentation. Conditions of admission include medical and surgical consent, release of information, financial agreement, and assignment of benefits. Now, the privacy rule. This was issued to implement the requirements of the HIPAA Act of 1996. It addresses the use and disclosure of an individual's health information. Hospitals must notify all Medicare beneficiaries who are inpatient that they have the right to dispute the hospital's discharge decision. The MOON, or the Medicare Outpatient Observation Notice, is required for Medicare patients who are in an observation status for more than 24 hours. The notice must explain why the patient is an outpatient and discuss the implications of the status, both for coinsurance and deductible, and eligibility for coverage in a skilled nursing facility. The patient has no appeal right, unfortunately. Advance directives are used to accept or refuse treatment on a patient's behalf when they are not able to do so. There are two types. A durable power of attorney, where they name a patient advocate, or a living will where they can state their wishes in writing, but does not name a patient advocate. The Patient's Bill of Rights was developed to promote and ensure healthcare quality and value, and to protect consumers and workers in the healthcare systems. Bed control, otherwise known as census management, is the activity which results in the accurate recording of a patient bed status and level of care assessment, patient's transfer and patient discharge status on a real-time basis. Clinical and service departments use bed location information in the delivery of services. Daily room charges are calculated based on the patient's location and level of care at midnight each day. Beds are assigned based on the patient's diagnosis and clinical conditions. Many times the physician's order will include a preferred locations. Most hospitals have units that are set up to treat certain patient types. Examples of common dedicated units include surgical, orthopedic, critical care, telemetry, and peds. Patients are placed on different units based on the required intensity of care. For example, you've got ICU, you got CCU step-down units, and then you have routine care. Each time a patient is transferred, a transfer request must be made to staff responsible for bed assignments. Transfers are required for medical necessity reason, isolation requirements, security reason, or unit utilization needs. The transfer is coordinated with both the receiving and transferring unit, and the registration system is updated when the patient is physically transferred. The patient access system may be updated by patient access or nursing unit personnel involved with the transfer. So again, for a good example, if a patient is in CCU step down in the morning, and then they are transferred to routine care in the afternoon, the bed charge will be the routine care, not the CCU step down, which typically has a higher cost. So discharge process, the physician must write the discharge order. Case management discharge planning must be finalized. Appropriate discharge instructions must be provided to the patient. Access services must or should review the patient record to see if the patient needs to see a financial counselor prior to discharge. Doesn't always happen, unfortunately. When the patient leaves, the registration system must be updated to reflect the correct dates and time of discharge and the correct disposition code. Did the patient go home? Did the patient go to a nursing home, a SNF, a rehab facility? All that is important to how providers get paid when patients are transferred to different locations of service. Okay, so the first polling question, I'm going to get that kicked off for you. Bear with me. I'm going to launch that. Okay. What does EMTALA require hospitals to do? To complete a standardized form signed by all patients, to provide a medical screening examination and stabilization, to confirm information that must be used to identify the patient, and to initially triage patients where a quick registration record is performed. Hopefully we can see that. You'll be able to see that correctly. All right, so it looks like we've got a good portion of people that have answered it. And the correct question is number 2. EMTALA prohibits inquiries about health plan information if the inquiry will delay examination or treatment, or if such activities suggest to the patient that treatment will not be provided unless the patient can demonstrate the ability to pay. All right. Okay. So it looks like most of you got it right. I think we shared the results already. We did. Stop that. Bear with me as I learn polling questions, guys. Okay. All right. Oh, another polling question. Hey, I don't normally do this. If the patient will not stay more than 2 nights, what is the right status? I'm going to get that second poll up. If the patient will not stay more than 2 nights, what is the right admission status? Inpatient, outpatient, observation, or emergency room? And as you're answering these questions, what you'll find when you go through the study sessions as well, and some of the questions, the way that the question is worded is going to give you a lot of guidance as to how to answer it. I don't think that they are trying to trick you, right? I think that they want to make sure that you're understanding the concepts and learning it, right? So there's a lot of times you'll say, yeah, that's the right one, right? In the relationship to this answer, right? This is really going to be making the decision between whether the patient should be inpatient or whether the patient should be observation, right? And the correct answer is this patient would be observation. All right, so again, just a trick there, not a trick, but again, just look at the wording, right? And think of the key concepts as you go through that, okay? All right. I just gotta get this to move. My apologies for that. Sometimes it gets stuck after the polling questions. Okay. So some of the key concepts that you want to make sure that you're looking at, right, is to, first critical step for all patients arriving for service is verifying the patient, getting the right patient. The downstream impact of getting the wrong patient is really severe, both from clinical care and some other things, right? Understanding the key concepts of EMTALA. And then what are the different admission process forms included that you're going to learn in this that section of the concept. So, all right. So now we're going to get into case management. We're going to talk about the purpose and responsibilities of case management used during the care of patients. A lot of people call it utilization review as well. The different types of case management reviews used within healthcare organizations, and then the roles and responsibilities of case managers in the management of patient healthcare. So as I mentioned, it may also be called utilization review or utilization management. As providers execute managed care contracts, enter into bundle payment arrangements, and other alternative reimbursement models, case management is crucial to the success of all of those programs, right? It's important. We need to notify our payers when a patient is admitted. If we miss that, and we're going to have to get into that utilization review, if I don't do it within the required time frame, sometimes between 24 to 48 hours of admission, I'm going to lose the beginning of this stage, right? So we have to stay on top of ensuring payers are notified. And then our utilization case management team, usually nurses, are going to be turning around, making sure they're working with the payers for that concurrent review. And they're going to be extremely helpful, particularly as you're going through denials and appeals and fighting things like length of stay, fighting things like whether it should have been inpatient versus observation versus inpatient. All those things, case management will be critical to trying to overturn those. So their responsibilities include monitor the use of resources, review stays upon admission and throughout the stay, which is called concurrent review. Gather information to manage the patient's care. Education for patient and family and home services when they're ordered. Discharge planning starts as soon as the patient is admitted into the facility and sometimes even before. The physician and case manager consider discharge planning as part of the overall treatment plan from the outset. There are 3 types of case management reviews. So there's prospective review or pre-certification before service, right? Does this patient need to be admitted for a scheduled procedure and is it authorized? Concurrent review and discharge planning during service. When should the patient be, discharged? Where should they be discharged to? An agreement of, again, length of stay, bed status, etc., with the UR nurse at the payer. Retrospective reviews, again, after service and working denials. The purpose of case management is to monitor the progression of high resource consumptive cases to help ensure effective utilization of resources during the care of the patient and maximize patient outcomes. Case managers are often nurses with specialized training in specific areas. Nurses may become certified case managers by taking specialty exams and having the appropriate credentials and experience. Both case management and disease management are methods used for managing the healthcare of patients. Again, they are responsible for coordinating care, routine contact with health plan, making sure that all the information is provided and needed approvals are obtained. Discharge planning and execution. If the patient is not moved timely, additional costs will be expended needlessly and can result in denials for not medically necessary for that length of stay. Case managers also assist revenue cycle staff with written appeals to health plans related to utilization and other care issues. Because they are involved with all aspects of monitoring the patient's stay, they are well positioned to document the clinical reasons for treatment decisions. These appeals may include not only a letter explaining what the clinical documentation indicates about the patient's outcomes, but also a copy of relevant medical records. As providers continue to address staffing shortage, particularly in those critical clinical areas and shortage of nurses, you're seeing more and more hospitals outsourcing that to dedicated companies that just focus on clinical and denial appeals. So our next polling question, get that up and running. In what manner do case managers assist revenue cycle staff? And it's a single choice. By estimating how long the patient will be in the hospital and what the expected outcome is. Oh, so I'm sorry, did I launch it? I did not, sorry. Here you go. All right. By estimating how long the patient will be in the hospital and what the expected outcome is, providing assistance with written appeal to health plans related to utilization and other care issues, with monitoring the progression of high resources consumptive cases, and by reviewing a patient's individual case and recommend treatment changes. Okay, give you guys another minute or so. There are a lot more sample questions and text questions out there on the HFMA website. So again, I encourage you, if you really want to pass, taking that end. All right, so we got most participants have polled. So we're going to end that poll. And the answer is number 2, because these clinicians are involved with all aspects of monitoring the patient's stay, they are well positioned to document the clinical reasons for treatment decisions denied by the health plan. Okay. Looks like you guys are all paying attention. Just move again, the slide gets stuck sometimes. Probably just me. Okay, so the key points that you should be taking away from when you go through this section is one of the keys to success in the management of patient care is absolutely a strong case management program. You can't not have one. Because these staff interact with the health plans, it is important that patient access staff correctly identify the patient's health plan at the time the services are initiated. Getting it wrong, choosing a PPO plan versus an HMO plan, and the PPO plan doesn't require notification, but the HMO does, right? Failure to do so may jeopardize the appropriate length of stay or result in non-COVID services being provided. So choosing the right insurance plan is key to moving forward, okay? Now we're going to talk about revenue capture. And we're going to talk about the charge process and its impact on the revenue cycle. We'll talk about the components of the Chargemaster, commonly referred to as the CDM. And then the maintenance of the CDM to ensure appropriate reimbursement, because if you don't maintain that CDM, you're going to have substantial denial issues. I've lived that nightmare once. I never want to do it again. All right. So accurate charging of healthcare services is critically important, as accurate recognition of revenue associated with the service provided is the basis for revenue recognition in the provider's financial statements. Even though relatively few health plans continue to directly reimburse healthcare services based on charges, it is important to understand how the charge process works and its impact on the revenue cycle. Room and board is typically posted from the midnight census. What status, bed status as I am, that's going to indicate what the room and board charge. Ancillary services, typically charged when the service or supply is ordered or when the result is reported. Scanning barcode items as they are used, surgery or materials management, and charged based on length of time or activity, things like surgeries. Audit trails are vital to ensure that all resources consumed are charged. Charges are grouped by revenue code for billing, logging, and case mix reporting, specifically to a hospital location. Most items have CPT-4, or we'll probably past that now, or HCPCS codes attached to make them easier to compare and track. Even with sophisticated cost accounting systems, providers continue to recognize that charges remain one of the few consistent indicators that providers and healthcare users have available to monitor resource use. Moreover, the logic of provider charge structure is becoming more important as a result of increased third-party and regulatory review. Charges should therefore reflect resource consumption accurately. So charges are very, very important. The Chargemaster is primarily a list of services, procedures, room accommodations, supplies, drugs, biologicals, and/or radiopharmaceuticals that may be billed to a patient, inpatient or outpatient. It also includes the charge-specific data needed for claim submission. So the core elements are going to be, what is my CPT code? What is my revenue code? What is my charge amount, right? Is it static or is it changing it based on timing? And the challenges that you have there is that charge masters are constantly being updated on appropriate CPT codes. You know, what was good for 2022 may not be valid for 2023, or additional charges were, added, right? And if you get it wrong, right, you will get denied. And I had that scenario when I was back at University of Maryland, where we had significant challenges to our Chargemaster. It was not maintained, and it resulted in significant denials, rejections, and write-offs because we didn't maintain it. So somebody in the organization has to own it, whether it is somebody in contracting, whether it is somebody specific to Chargemasters. Many times it falls back to the revenue cycle. I know it did to me, because it is so key to getting paid appropriately and timely, that many times it'll sit in finance, it'll sit in the revenue cycle, and they'll maintain it, typically using third-party technology to ensure that it's appropriate, any updates, etc. Okay. So the core elements, as we talked about, you're typically going to have a CDM number is a unique identifier assigned to a given line item in the Chargemaster. The department number denotes the revenue generating area, so it goes on to their financial reporting. Charge description, that's going to be what appears on a claim or a statement to a patient, right? They don't understand CPT codes. What's the dollar amount or total charge amount? CPT codes are maintained by the AMA. They describe services, procedures, and drugs. They are typically updated in January and July of each year. HCPCS is maintained by CMS and describe services, procedures, DMM supplies, and drugs. They are updated continually throughout the year, so you have to stay on top of it. Modifiers are a 2-digit alpha or numeric character that can be appended to a CPT code to provide additional information about a code. Revenue codes are typically a 4-digit number established by the National Uniform Billing Committee, NUBIC, that characterizes, classifies a line item in the Chargemaster. And then it'll have a GL or general ledger number. And that's that number used for accounting purposes that directs the revenue to the appropriate department. Again, there are lots of challenges, right? The omission of charges, not all charges considered, is going to result in mixed revenue. Obsolete or invalid codes results in claim denials and negatively affects reimbursement. The omission of required modifiers results in health plan denials and or impacts revenue. Right, charges are the basis for third-party and regulatory reviews of resource consumption. An out-of-date Chargemaster can result in poor data quality for results, trend monitoring, billing compliance issues. So it's really important to maintain it. Okay. Often maintenance of the Chargemaster is assigned to a specific individual or department. However, others within the organization must be involved in adding, revising, and deactivating charges. It is critical that the CDM is reviewed and updated regularly to ensure it supports and represents the services provided within the organization. In addition, ongoing education should be provided to staff to ensure code and description charges are communicated to the appropriate service area department. When I first started at university, I inherited a not well-run revenue cycle, lots and lots of denials. And my billing supervisor came in and said, well, this could be it. And there was documents and documents of the Chargemaster recommendations that was done by a third-party company. And none of them were maintained. None of them would change, right? They had all these documents, but nobody did anything with it, resulting in continued denials. At that point in time, it was obsolete. We had to completely redo it. But what we decided to do is do it department by department. We know which departments were the most critical. So we focused on lab, then we focused on cardiology, then we focused on radiology. So we did it department by department to ensure that it was done and actually implemented so we could maintain that. So then you've got your HCPCS codes and your modifiers. Level 1 modifiers are the Approved Medical Association CPT-4 codes. They are all 5 digits. CMS developed codes level 2 for classifying supplies and non-physician services such as DME, ambulance, and drugs. Level 3 are assigned by the MACs. These codes are not common and are used basically to describe new procedures not yet developed in level 1 and level 2. Modifiers are typically assigned via the CDM process, but some can be assigned via coding. Level 1 modifiers can discuss common scenarios such as bilateral or multiple procedures. Level 2 will designate a right or left side or part of the eyelid or hand or artery. Level 3 modifiers differ significantly because they are signed by each MAC, such as cosmetic surgery not commonly covered or an FDA approved drug. So common issues: incomplete or vague physician dictation or documentation, coding from face sheet of an incomplete record, systems instead of specific diseases, and then coder mistakes, primary diagnosis and procedures. Right? Since the introduction of CPT codes, okay, codes and Medicare fee schedules in the 1980s, so outpatient procedures are paid based on these codes. Reimbursement is adversely affected by the listed issues. So, next polling question. Let's get this. All right, so you should be seeing it now. Why is it critical that the CDM is reviewed and updated regularly? To ensure the most appropriate measures of the utilization of resources, because charge descriptions can vary greatly between providers, to ensure it supports and represents the services provided within the organization, and so the CPT databases can have the most current and accurate information. Give everybody another minute. I think we've got most done. So we're going to end the poll and we're going to share the results. And I could see why there's some vagueness there. As I mentioned, you have to really think about the question. There's only going to be one right answer, and they're going to have issues that are there. So when you go into the HFMA website and you start going through the polling questions, and most of these are on that, I took right from there. It'll tell you why one question is right, why one question isn't. So again, it's reading it and interpreting it. So, but number 3 is the correct answer. It is CDM is a list of services and supplies that may be billed to a patient. It also includes the charge-specific data needed for claim submission. Right, so it represents the services provided. So that is the correct answer. Number 4, certainly it sounds like it could be, critical, but the right answer is number 3. Okay. Close that up. It's moved along. Okay. Oh, another polling question. All right. Bring that up. Which HCPCS level modifiers are maintained by the max? We'll launch that out for you. Which HCPCS level modifiers are maintained by the max? Level 1, level 2, or level 3? Most of you participated. We'll move this along. And the correct answer is level 3 are maintained by the max. Okay. Most of you got that one right. Okay. So as you move on, right, you want to keep in mind the following points. The 3 levels of HCPCS modifier include level 1, approved AMA, level 2, CMS developed codes, level 3, done by the max. It is critical that the Chargemaster is reviewed and updated regularly to ensure it supports and represents the services provided within the organization. In addition, ongoing education should be provided to staff to ensure code and description changes are communicated to the appropriate service area departments. Additional points to keep in mind: it is important to capture charges in an accurate and timely manner for the services provided, as this gives the most appropriate measurement of utilization of resources and thus resource management. It is important to understand HCPCS codes and modifiers, since their appropriate use can impact reimbursement. Okay. All right, then we're going to get into coding, and we're almost done here, guys. Try to get through this pretty quickly. We're going to talk about HIM and its impact on the revenue cycle, how diagnosis and procedure codes are used to communicate the reason for treatment, and how other departments and stakeholders utilize the information as it pertains to the revenue cycle. So what is HIM? They are responsible for the management of all patient records, which reflect all the care provided to the patient and a description of all clinical symptoms and diagnoses. They are the primary source for clinical data required for reimbursement by health plans and liability payers. The medical record is reviewed for the patient's clinical information, and the information is coded into the medical record system. Claim information is then electronically passed to the patient accounting system to meet claim data requirements. HIM plays an important role in ensuring the accuracy of the codes documented on the claim. The HIM department completes several important activities, including ensuring the security and completion of electronic and hard copy medical records, transcribing physician dictation, including history and physicals, operative reports, and discharge summaries, analyze information necessary for decision support, perform chart analysis, and of course, reviewing the medical record, assigning diagnosis and procedure codes, and classifying data for reimbursement. Once all of the above has been completed, the account can be deemed final billed and should then create a bill to submit to the payer or patient. They must monitor all required physician documentation to ensure that the volume of discharge not final billed, or DNFB, does not continue to rise. If accounts remain in DNFB for too long, due to untimely documentation completion or lack of coding staff. This can seriously impact cash. Completion of medical record requests and ensure the release of records is done in a compliant manner based on HIPAA regulations. An EHR system, or an electronic health record, is a digital version of a patient's paper chart or medical record. EHRs are real-time, patient-centered records that make information available instantly and securely in authorized users. While an EHR does not contain the medical and treatment histories of patients, it is built to go beyond standard clinical data and can be inclusive of a broader view of a patient's care. It can also include things like immunization dates, allergies, radiology images, and laboratory and test results, right? So it maintains and does contain the medical and treatment histories, but it goes way beyond that. The EHR is the connection of the clinical document process to the coding and charge processes that support claim generation. Clinical documentation is the source of all diagnosis and procedure coding, and the detail and specificity of the documentation by physicians and staff, including clear documentation of all comorbidities related to the patient's episode of care. Failure to properly code the primary reason for treatment, along with all comorbidities like diabetes or obesity, can negatively impact reimbursement. Each caregiver must be precise and accurate in the clinical documentation to support. There are two types of coding systems that are used to communicate the reason for and type of clinical services provided to the patient. Diagnosis codes are represented by ICD-10 codes that can characterize the medical condition that a patient is experiencing. Examining things like abdominal pain generalized is ICD-10 R1084. While the ICD-10 transition was no laughing matter for most providers, the federal government, with their exceptional ability to over-document everything, has created a series of diagnosis codes that had us cracking up, right? One of my favorites is hurt at the opera, Y92253. You know, I guess that the fat lady gets cranky when she can't sing. I mean, it's really hurt at the opera. So the CPT code, HCPCS code associated with a service or drug may be listed for a specific charge in the Chargemaster and is deemed hard-coded. It is typically only used for procedure coding. When an HIM coder is responsible for reviewing and assigning the codes, that is deemed soft coding. It includes the review of the clinical documentation in the medical record prior to final code documentation, and that is typically seen in things like surgery. So again, there's hard coding that's going to go from the Chargemaster, soft coding that's going to be coded based on the surgical event. Beyond HIM, a number of departments rely on the codes that are assigned. Reimbursement and budget personnel actively model coding and reimbursement changes, both positive and negative, that result from the coding and assignment of MS-DRG or CPT codes within that. Controls are typically put in place to guard against unintentional downcoding or upcoding, which are potential compliance issues. The enhanced data mining opportunities that result from the more detailed coding under ICD-10 allows senior leadership to work with physicians to improve outcomes, embrace new reimbursement models, and drive significant areas of quality and the patient experience. Diagnosis and procedure codes are used to validate medical necessity. These codes must be documented prior to the provision of healthcare services to a patient and map correctly to the health plan authorization requirements. This ensures that authorization requirements are completed and patients are informed if the service will be covered by his or her health plan. Lack of prior authorization usually results in a denial to the provider that is very, very difficult to overturn. The patient accounting system typically uses a number of claim edits that claims must meet all health plan requirements prior to submission. Failure to comply with those requirements will result in rejected claims. The correct coding initiative edits or NCD's LCD edits are an example. Okay. So another polling question. What is the responsibility of HIM? So I'm gonna get that polling question loaded for you. what is the responsibility of HIM? And they have many, to maintain all patient medical records, to make information available instantly and securely to authorized users. I didn't launch it, hold on a minute. There you go. To denote the medical procedure performed by a healthcare provider on a patient, and to substantiate health information claims filed by the patient, the physician, and the provider. And this is, again, probably a really good one where you go out into these questions and you choose your answer. It's going to tell you why it's wrong. You go to the other ones and it'll tell you why it's right or why it's wrong. So it's a good example of that. So the correct answer is number 1. And most of you have gotten that right. So HIM has custodial responsibility for records that include tracking records, temporary filing for incomplete record, and permanent filing for completed records. Number 2 refers to EHRs, which are real-time patient-centered records that make information available instantly and securely to authorized users. Number 3 refers to procedure codes represented by ICD-9 and CPT codes HCPCS. And then number 4 refers to a medical record, which reflects the care. And that is the primary source for the clinical data. But the main responsibility of HIM, although they might be included in some of that stuff, definitely not number 2, is going to be custodial responsibilities for records that include tracking records, temporary filing for completed tasks. So go through there, okay? And we'll just move this record along. Okay. And that was it, your key points, right? Health information management is responsible and is a critical factor for maintaining your patient medical records. It plays an important role in ensuring the accuracy of the diagnosis and the procedure codes, right? And the importance of diagnosis codes reflects the reason the patient needs clinical services. Using ICD-9-10 codes and procedure code communicates the type of clinical service using CPT codes, HCPCS codes provided to the patient, right? And that was our focus for today. So I'm going to stop there and see if there are any questions in the chat. If anybody wants to come off mute and ask a question, even if it's just, guidance on how do I take the exam, what are some things we should do, I'm certainly happy to chat about that. I'm not seeing any active questions in the chat, but we'll give you all a minute or two. If not, you all got a few minutes back in your day.
I do have one question.
Sure.
You had indicated that modifiers were 5 digits?
No, HCPCS codes.
Yeah, that I knew, but I thought you said something about the modifiers being 5 digits. I thought those were 2, right?
No, I thought it was HCPCS. Mm-hmm.
Okay.
Modifiers are going to be 2, like 50 for bilateral procedure and stuff like that. So I might have misstated it, but it's your HCPCS codes, your CPT codes are typically 5 digits, whereas your modifiers are typically 2.
Thank you.
Mm-hmm. My apologies for misspeaking there. We did have a question for the previous recordings. If you go to the Florida YouTube channel, I have asked my admin team that maintains both the chapter resources and our YouTube channel to take these recordings and load them up. So they should be there. If you cannot find them, just send me a note and I'll ping them again. I hope you can find that helpful. Again, highly recommend that you're trying to take the online course for training for the CRCR as you're doing this, whether it's right before, and this is going to get you those key concepts, or you do it right after to kind of refresh your memory on what we talked through today. I would highly recommend spending about an hour a week going through that and then using the study guides. The key concept guides are all out there to give you some guidance as you go through that. Other questions? Okay, Well, if not, hopefully you're finding this helpful. And any feedback, certainly feel free to share with me. You should all have my contact info. It's christine.fontaine@waystar.com, or send it to the chapter leadership and I'll make sure I get it. So, all right, give you about 5 more minutes out of your day. Have a great week. Have a great holiday. I will be not doing next week's training session. Either Natasha or Cassandra will be on, but I will be talking to you in the next few weeks. All right, take care, guys. Bye.